Our next session is management of long stayers in the cardiac intensive care unit. I would request Professor Debashish Bandyopadhyay to chair this session. Sir is head of the department Pediatrics, BR Singh Hospital. And we have Dr. Sri Lakshmi as moderator. Ma'am is additional associate professor, Department of Cardiac Anesthesia, Amrita Institute of Medical Sciences. And I will request our panelists, Dr. Ritajyoti Sengupta, consultant pediatric cardiologist in Artix Hospital, Dr. Shivani Gajpal, consultant pediatric cardiac anesthetist in NH Super Specialty Hospital, Dr. Shatarupa Mukherjee, consultant cardiac intensivist in BM Birla Hospital, and Dr. Muhammad Ali, consultant cardiac intensivist, Mission Hospital.
Hello. Thank you so much. I would first of all like to thank the organizers of this conference, and especially to Shubhadeep for inviting us all the way from Kochi. I am Dr. Sri Lakshmi. I work in our pediatric cardiac unit in Kochi, Amrita. So today we are going to discuss a very important topic. It's the management of long stays in pediatric cardiac ICU. And as all of you know, they are the subset of patients who take up a lot of resources. They are like a strain on the entire team. So thank you for the kind introduction. They've already introduced all the panelists. I would. So this is my hospital. It's a very beautiful place, Kochi, so do visit whenever time permits. So our panelists has already been introduced. Dr. Ritajyoti, Dr. Shivani, Dr. Shatarupa, and Dr. Muhammad Ali. So, and our distinguished chairperson, Professor Debashish Bandyopadhyay. Thank you, sir, for joining us. So we will start with as to why is it important for us to identify these patients, and is it possible for us to identify them preoperatively, and how to do that? So first of all, why we're having this discussion is because this particular set of patients are associated with poor outcome. It's shown in multiple studies. And again, the burden on the resources. We are a low resource setting. And so probably where we can manage like 10 other cases, we spend that much money on one child. And then again, it's an organizational challenge. So I would start the discussion with Dr. Ritajyoti. So Dr. Ritajyoti, so how do we define long stay, and how to identify these children preoperatively?
Thank you, organizers, for the opportunity. Respected Chairperson Sir, Moderator Madam, and my co-panelists. As you know, we all have come across long stays in our ICU, and we have seen that there is no fixed definition for long staying in the ICU. We first calculate the length of stay from the day of admission to day of discharge plus 1 day as length of stay in the ICU. And depending on that, when I searched the literature, I found that there are various definitions for this long stay, like beyond 5 times the median length of stay, that is usually 3 days in one study after cardiac surgery. Another one showed that beyond the 95th percentile of their length of stay in their ICU. Another definition was purely statistical, that is greater than 2 standard deviations from the mean in Gaussian distribution in their statistics. So depending on these studies, I can say, please next slide, please. Previous slide, sorry. So the definition can be said as 12 to 14 days in pediatric cardiac intensive care can be considered as long stay patients.
Thank you.
And
yeah, so then now we can go on to as to how to identify them preoperatively, and yeah, like, is it possible for us to do that?
If you are working in cardiac intensive care, and if you see few things that is evidenced in the literature, that these patients might turn into long stayers in your ICU, like preoperative risk factors, if they are too young, premature, sex is female, presence of chromosomal abnormalities, and pre-op ventilated, the child is already requiring inotropes for ventricular dysfunction, LVEF is less than 25%, these can be considered as pre-op risk factors. Whereas, if you are doing congenital heart surgery and you found the basic Aristotle score is higher, or the RAX1 score is higher, like RAX4, RAX5, truncus arteriosus, or Norwood operation we are going to do, or interrupted arch repair, or the surgeon has taken a longer time for cardiopulmonary bypass, or aortic cross-clamp time is higher, or he might have required hypothermic circulatory arrest. These factors can lead to long stay at the end. On the other hand, postoperative risk factors, we all know, if the child is having prolonged low cardiac output state, or the child is having circulatory shock in the ICU, significant postoperative arrhythmia requiring pharmacotherapy or pacemaker support temporarily, acute kidney injury requiring respiratory insufficiency, mechanical ventilation more than 7 days, and of course, one important factor, delayed sternal closure, either primarily inside OT or due to any cause the surgeon has opened up the chest inside ICU, or patient is having single ventricle anatomy requiring chylothorax or pneumothorax, or prolonged pleural drainage for single ventricle, then we might land up into long stay in the ICU. These things are depicted in these two papers as I search the literature, European Journal of Cardiothoracic Surgery 2011 and initially 2003 Heart, Lung and Circulation.
Thank you so much. So this is like what all of us do commonly face, all these factors. So it's something that we can keep in mind. So next, I would like to ask you, what is the importance of involving, Dr. Ritu Jyoti,
So,
what is the importance of involving family in the care of such patients?
As we see that long stay going to cause immense burden to the unit as well as the family. It generates cost, it occupies the bed, more complications from the primary complication as well as secondary complication due to long stay, like physical medicine related problems like contractures, pressure sores, more hospital acquired infection, nutritional issues, emotional burden. So if we have to combat this thing, we need to involve the family as family centered care. Means we need to involve the parents also to prevent the complications. We need to establish a partnership between the parents and the child and child's family. We should not look the child as only as a patient, but as a whole to the family, we need to care our support. The parents can partner with the nurses about comfort care, feeding practices, pain management. By this, we can allay their fear and unexpected outcome, and we can make better outcome for them.
Thank you so much. Thank you so much. So, so involvement of families, we can also like talk to them before taking our patients in. We do that sometimes when we anticipate a long stay, just so that they're prepared, and we tell them like your child is going to be there in the ICU for some time. So my next discussion will be with Dr. Shivani. So we'll go ahead to the ventilation part of our long stays. We see that some of them end up on ventilators for a long time for various reasons, and Dr. Rajesh's talk was on that, and he's elaborately explained as to the different causes. So I would like to say, like, how do you manage in your unit the long stayers on ventilator? What are your do you have a VAP protocol and your sedation management?
Okay, so we have already discussed many of the topics before. So first, very important thing is that again we have to categorize which patient will be on failed extubation category, which one are the ones will take the longer ventilation management, and it is a corroborative of everything. Like you, I'm definitely talking about only the pediatric cardiac intensive care. So where we mostly found the patient having long ventilation management, they are the patients, Rituda already told, high complex surgeries with The most important thing we didn't say about that is the congenital syndrome. The syndromic babies, they definitely take long ventilation, and the most important reason is the failure to recuperate the extubation because of the airway anomalies, and because of the syndromic, and because of their malnutrition background, the babies which are failure to thrive. So taking that into consideration, we just first of all, we always try to give the extubation we try to give the extubation trial to these babies, because long ventilation invariably responsible for VAP, ventilator associated events and complications. So the management is the most important in pediatric intensive care unit, is that we use mostly the pressure control mode of ventilation. That is the most important thing, exclusively in every patient, having low tidal volume and the minimum PEEP required. And to take care of the VAP bundles, which is very important, because invariably if the patient is getting ventilated more than 24 hours, we will have the other complications going on. So the VAP bundle which we think about which seems to be very simple and very easy, but it is very important that taking care of the baby in a proper position, trying the taking the ulcer prophylaxis, and that invariably is responsible for infection, because the ulcer prophylaxis, the loss of acidic pH is responsible for colonization. So we have to balance that. And if you're thinking about there is a prolonged ventilation, feeding is very important. Enteral feeding we are not giving sometimes because of the trial of extubation. We just, as discussed earlier, we keep on stopping the feeds and then again resuming very later on, and this goes on and goes on. So we have to take care of that. And the last one, most important thing, is hand hygiene, which is very important because it is responsible for most of the infections. Then regarding the inline care of the endotracheal tube, is very important to use the inline suction very gently, the suction, taking care of the suction pressure, because it can lead to lung injury itself. That is very important. And taking care of the site, that is very important.
So how is do you paralyze your patients who are on ventilator?
So the most
protocol?
important thing, these are very small babies, so mere sedation works most of the time. And even if we need to paralyze, we do only intermittent paralysis, but very less. So our protocol is to, when the patient gets awake after shifting from the OT to ICU, when the patient starts awake, we give the bolus dose of sedation. Most commonly is fentanyl and morphine used in our setup, and then we start the infusion morphine. And very rarely I found the child to be struggling onto that mode of sedation. So paralyze we use very minimal, and paralyze per se is having very bad effect because we lost the tone, and that again is responsible for long ventilation.
Right. So the same thing in our unit as well. So prolonged ventilation babies, we tend to let them move, let them breathe. So in those cases, as Rajesh has already discussed, we put them on SIME to assist their own breaths. And one thing that we have done, as he said, is 2.5 years back, we implemented lung ultrasound. So we go and treat, pick up possible concern. It's difficult to delineate consolidation, collapse, but when you see it, we kind of open up the lung under vision, and I think that has helped our unit to have a larger turnover as the numbers that he had shared, and that has helped us. I think it would be a very useful tool if you can implement. It's very easy also, but to convince the entire team is difficult because we understand it better than the surgeons. I think the lung.
So sorry to interrupt you, I want to add that point also. It's very important because X-ray never, we always say that the clinical factors and the radiological evidences, they will not go hand in hand. There is always a lag between this. So sometimes we find the X-ray to be very absolutely normal, but we are finding that the child is not able to extubate. And most of the times the cause is, apart from the cardiac, is the lung. So rather than hitting on to all the points that we need more diuresis, or we need to open up the collapsed lung, or there is atelectasis, or there is some pneumatocoel, or there is some, infection going on, or some infiltrates have started to act. So we can use this lung ultrasound, and it helps in differentiating the cause, and will start the treatment right as early as possible. That's my thing on
I think so.
lung
It's a
ultrasound.
very useful, we find it very useful actually. Thank you so much, Shivani. So now we'll go on to the next very, very important part of our discussion. That is about sepsis in these long stays, and it's like one of the most dreaded complication of long stays. So I would like to ask Dr. Muhammad Ali. So what do you do to prevent sepsis in these children, and what is your policy for prevention of sepsis?
Sepsis is a major problem, ma'am, particularly in our setup. So there are lots of issues because the involvement of the higher authorities, the managements, the motivations of the team, the knowledge of the nursing team as well, the infection preventions, what is written in the guideline and implementations to the patients, there is a gross difference, and other many issues are there. So what we found is the infections or sepsis or hospital-acquired infection is very common. So if you go to the literatures, it will say the incidence is up to 30%. So that depends, like again, there are some factors, that is the patient-related factors, the age, the weight, malnutrition, and so many things we have already discussed. That's actually predisposed these ICU patients in basically in sepsis. So multiple lines, interventions, and so many things are there that can predispose there for sepsis. So for prevention of the sepsis, I think there are lots of literatures and standard guidelines are also there. So in like in cardiac ICU, we should have at least 4 prevention bundles. At least one is for bloodstream associated infections, second is ventilator associated infections, then catheter associated infection, and surgical site associated infection prevention bundles. So that there is a lots of guidelines are there. So in in our ICU we follow, we have infection control team. They regularly come and visit. They strictly monitor the hand hygiene policy, what is being followed by the nurses as well as the doctors. They also regularly see our antibiotic charts, their indications. They also see whether it is correct or not. As I said, there is some problems as per the guidelines and the implementations. So still sepsis is our major problem in our ICU. CLABSI is the central line associated bloodstream infections. It is little bit different from the central line related infections. But for the practical purpose, if you consider the prevention perspectives of bloodstream infections, then there is not much difference. So for prevention, the CLABSI, what we follow in our unit, we actually for surgery, all the patients will get central line insertions, and there is a protocol that we follow. And there will be a nursing staff inside the OT who will see the checklist, what is to be done before putting the patient on central line. We usually follow ultrasound guided central line insertions. We use chlorhexidine, and we use transparent dressings. We do not regularly change the central line unless there is sepsis or there is a problem with the dressings, these things. So, and antibiotic stewardship, most of the part I have already discussed. So we have infection control team, the clinical microbiologist. Clinical microbiologist is the team leader here. So we have to coordinate with them, and that's why we have to ensure the right drugs, right dosing, right route,
and when to stop,
right durations and de-escalations. These 5 Ds has to be ensured in antibiotic stewardship program.
Thank you so much. So in our unit, what we do is we just remove the central venous access as soon as it's not required.
Yes,
So unless there's a specific indication for it, we don't keep it, because the turnover of nurses in our ICU is huge. Like every 6 months, we have the entire nursing to be new staff. very difficult to teach all of them. So the best strategy that we have found is you don't need it, you remove it. Simply because we're there 24 hours. One of us is there on call. So if you need to put it back, we are there to put it back. So even in those borderline cases, we just remove the central line unless it's really indicated. And another thing about our antibiotic stewardship is that, so the moment we start a second line antibiotic, the team comes, ID team comes in, and we have to give a written explanation as to why we're starting it. And we stop as soon as we have a negative culture. So we send a culture prior to the starting initiation of a second line antibiotic, wait for the culture, and if it's negative, then we stop. And in case of a positive blood culture, we continue. For neonates, we continue for like around 14 days. That's a number all of us like. Or with followed by a negative culture. Okay, so thank you so much. Yeah, anything else to add?
One thing to add. Like a sepsis diagnosis, like when we'll start second line antibiotic and third line antibiotic, what we follow in our ICU is, we follow the trajectory of the patients. So we have some kind of idea that these patients will behave in this way. So if there is deviation at any point of time during the ICU stay, then we consider sepsis as one of the problems that might cause this. We always rule out the cardiac cause, respiratory cause, and other things that may cause this acute deteriorations. But if you suspect like sepsis as a parameters, then we send some investigations. If that is corroborating, then we will escalate the antibiotic therapy.
Do you go by like Procal? What do you do for the following up? Do you follow Procal or CRP?
We do total count and differential count and CRP, procalcitonin, like case to case basis. It is not regularly done. Okay. So we see the trend.
Of this we do the same.
Yes, ma'am. And we have seen is like the count is more than 20,000 or fever for 48 hours after the surgery. Platelet count is low and the inflammatory markers is showing in the rising trend. Then we will start antibiotics. As you said, after 48 hours of cultures, if that is sterile and patient is showing remarkable improvement, then we assume that it is not because of the sepsis. We stop the antibiotics.
Thank you so much. Yes, Dr. Shataruba, another very important aspect of long stays, and I think this is like the most important one, because how do you manage in your unit the nutrition in these children? Because most of them, like has been mentioned in previous discussions as well, will be kept nilparoral, no enteral feeding. So I would like to ask you, like, when do you initiate enteral feeding in these children? And if you're not able to initiate, then when do you go for a parental nutrition?
So yes, this is one of the challenging and the most important part of long stays whom we get. So post-operatively, like immediately after the surgery, they are in low cardiac output, they are on high dose inotropes. We will not feed them for at least 24 hours. But once we are at a reasonably low dose of inotropes, and their hemodynamics are stable, we don't wait for the inotropes to be stopped, and we are sure that the like bowel sounds are there and the bowels are moving, then we start them on trophic feeds, and we rapidly progress depending on their tolerance. Few subset of patients who we are not able to start enterally, like pre-operatively also, like coarctation of aorta. This set of babies whom we don't start off, but we wait for at least 48 hours before we see that the baby is stable enough, the urine is adequate, and how is the echo, and then we go ahead with a small amount, and then we progress a bit slowly. For a subset of patients whom we are not able to progress the feeds, particularly they are the post-operative babies who are on vasopressors for quite a high dose, we see that their abdomen is distended, they get bilious aspirates. We really have to wait for some time, but our unit, starting a TPN, we usually wait for 7 days. So that might have a big nutritional impact on our babies, but I think there are recently published some studies which have shown us that yes, we can wait for 7 days, and that's associated with less side effects than starting TPN early. So we will push in for enteral feeds. When there are like these abdominal distension issues, we speak to our surgeons and we get x-rays done, and then we see what type of abdominal aspirates we are getting. And then we just start off with trophic feeds, and then we progress rapidly. So the stress is on enteral feeding. Because in this resource limited setup where cost is an issue, getting a TPN, and that to a TPN without a lipid. Because giving lipids, that the cost becomes like 4 times. And we need to have a dedicated like a line for giving the enteral parental nutrition. So we go and start with feeds early. We just push in the feeds until unless it's really contraindicated. That's until unless it's a surgical contraindication. So that's how we decide and go ahead. And definitely our dietitians are a big help here. Yeah. So they will be coming
So you target
regularly.
calories per day?
Yes. So we start with, for small babies, like 100 kilocalories per kg per day. We go with to 150. For a bit elder kids, we'll start with 80 and then we'll go ahead. Yeah. So that's also like sometimes if you're not able to achieve, we'll add on like a calorie dense feed, and rather than going up on the volume. And as we were discussing before, like our kids are always volume restricted. Like we can't give them full. Like we'll give them 80%. But usually if it's enteral, I think we can go up rather than giving IV fluids. So, but still we can't give them more because they will be fluid overloaded and the cardiac functions will get. So we'll try to make it calorie dense and see, and and if not if there is intolerance. So feed intolerance, that's also is, I think it's more of a perceived issue rather than actual it is. So
how do you assess intolerance in these babies?
Yes, so it's a common trend to measure gastric residual volume, but there are like controversies like whether we really need to measure them or not. So we go at don't measure it every second hourly, like every time we feed. We'll measure it every 4 to 6 hourly once, and that too but otherwise clinically we'll go like if the abdomen is soft and the baby is fine, we'll just increase and go ahead. Otherwise if the aspirate becomes bilious, then only we're like, we need to wait, or but we don't stop it absolutely. So it's we in our unit will just say that it's like we'll ask 5 times before we decide on to coming down or stop a feed. That's what I think is.
What is your experience on intermittent versus continuous feed?
Sometimes these kids they're not tolerating intermittent feeds. We'll go on
because of the
continuous
volume.
feeds. Yeah, so continuous feeds are better tolerated at times, and that too nasoduodenal feeds like post-pyloric feeds. Sometimes, but post-pyloric feeds.
Can't give volume.
Sorry?
You have to give slowly, right?
Yes, that we have to give continuously. And that too, the insertion, sometimes we do it insertion like in the ICU itself, we'll insert it and they get an X-ray to see if it had gone to duodenum. Then we see it's not there, and then again we do an X-ray and see. Better to go it by fluoroscopy guidance, but still we sometimes do it and just give some prokinetic to push in the tube more, and then we'll go ahead with continuous feeds.
One very useful thing that, I'm just talking about the bolus and intermittent. What we used to do is, even for the bolus feed earlier, what our nurses used to do is they just attach a syringe and then pour the feed and then allow it to gravitate into the stomach. But that practice we have found has led to more of a distension. So then what we started doing now is we put the feed in a syringe and give it over an hour, the same volume. So we found that the stomach actually accommodates, and the same baby who we thought was not tolerating feed was actually tolerating this feed when it was given slowly over an hour. So that is one thing that we implemented very recently, because earlier we never really get into the nursing part of it. But then I saw that the child is otherwise okay, but not tolerating feed. So then I just noticed that this is the way they were giving. So then in one of the talks they said they give it like this. So I thought, okay, let's try that. But that worked. So it was not really an intolerance, I felt. So I think the intolerance should be like more of a clinical assessment, and then work upon it, and then try enteral. And for some of our long stayers, we have a bit. So, when do you consider gastrostomy, or have you done that? I mean,
yes.
How is your policy on that?
So that also we wait for some time to see what's the cause. Really, we have to find out before we go in for a gastrostomy. It's again like counseling the parents for one more surgery, and that it's a so we'll see.
Difficult decision to
Yeah,
make.
difficult decision. So like we had a this reflux, babies do reflux, and it was quite a significant reflux, and the baby was not failing to thrive. Those cases we do go in for gastrostomy. But then again, I think post-pyloric feeds, giving it for some time, why the child is refluxing, we need to find out the cause. Is there any allergy is there any cow's milk protein intolerance that's causing the reflux? What is it? And then avoiding this, going in for elemental feed, like peptide-based
Changing the type
formulas.
of feed.
Yeah, peptide-based formulas, whether that is causing less of reflux. And then finally, we do land up in getting gastrostomies, but we need to really see what's happening, and then that's our final thing. There are many steps before that.
For us, when we just want if the baby is there only for feeding and we are unable to establish a proper enteral feed, then we think we had a baby who stayed with us for almost 3 weeks, and then we thought, okay, fine, gastrostomy, and then he fed him, and then we sent him because we had to send him from the ICU somehow. And another thing I wanted to ask you is, what about in preterms? How is nutrition balancing in preterms different from the rest of the babies or the other neonates?
Yes, preterm babies, as we already know, they are they need more of protein, more of calories, and they are IUGRs.
What preparation, which type of feed do you give them?
Which type of
feed?
Yeah, so definitely express breast milk, breastfeeding. But if we don't get that, then and that too, the milk should be fortified, and otherwise, we give this
MCT oil.
Yeah, we can add MCT oils. We do add these multivitamins. That's early. We have to add of iron and calcium, phosphorus. We'll do for these babies once weekly this metabolic parameters. And definitely breast milk, otherwise we have to go in for formula. But that to start early, give fortifiers, and then we'll assess the nutritional status definitely.
How do you do that? How to assess the nutritional status?
Yes, we'll definitely wait for age. Definitely we'll use weight, length, and head circumference. And for bigger babies, we can use the upper arm circumference.
So how often do you suggest we should be checking weight of the?
At least every alternate day. Usually at times in the ward we'll do it twice a week, but in ICU we do tend to do it
more frequently,
every alternate days. Yeah, but it's difficult when a child is on a ventilator, and you need to know the weight of the different parts as well. When you weigh the baby with the ventilator, I think the ventilator tubing should be weighed before that. So, and we should have written that these things weigh this much, and then we can subtract that, because that too. So taking at least twice a week, and for ICU babies at least every alternate day.
Thank you so much.
Thank you.
So that's it. Our discussion comes to an end. So one thing I wanted to say is that how important it is to screen. To do a screening echo in these long stays, because we've had this baby who was there for a long time, and then he was just stuck with various reasons, and an echo was unfortunately not done for almost 2 weeks, and then he had an infective endocarditis which was not picked up and things like that. So I think once we have a baby who's staying for more than a week, we need to do the screening system wise, all the systems, respiratory, cardiac as well, and renal, nutrition, the physical medicine, rehabilitation. So basically, a long stayer means it is not just the intensivist who is required for the baby. The baby needs a family, the respiratory care, the nutrition, the PMR, and so it's a combination of doctors who should be taking care of them. So, so I would just like to sum it up as our long stayers can be identified preoperatively, and when they are, we need to counsel the parents, the family, so that they are prepared for a long stay. So they need to, the financial burden as well as their mental and physical burden that they will have to go through to see their child in the ICU for that long. It's not easy. So we have to consider the family definitely. And when they stay for a longer time, we need to involve other physicians, other disciplines to take care of them. Nutrition has to be taken care of and to be given a very big role, because they once their nutrition is picked up, they do better. And another thing in preterms also, when we put them on dextrose, it's important to calculate the GIR. And most times in what happens in our ICU is that they have the stress-related or the inotrope-related hyperglycemia. So we cannot give them much of a dextrose dense fluid. But what we do is we do give them their required GAR, but then we supplement with insulin to bring down, rather than coming down on the percentage of dextrose, and that's very important. And then again, the prevention of long-term complications. So even like that comes from where the baby is being nursed. So the bed. So we've custom make our water beds for the little babies, and for the older children we have the alpha bed. So that is important. The way they are sleeping, we kind of encourage the mother to come in. We had this ventilated baby, but then we encourage the mother to come and talk to the child, like that. And then the music therapy, the rooming in, it's very important as well. Lung ultrasound, definitely. We found it it's a very useful, easy tool that can be implemented in these babies, because things that probably X-ray cannot pick up, our lung ultrasound does pick up. Plus we can do real-time expansion. We have done that many times. Crazy things like the entire lung was collapsed. We just bag masked and opened the lung, and the baby was okay. So, and we picked it up because our X-ray comes only like once or twice a day. And it's a cumbersome thing which comes, and ultrasound can be done like right at the moment. And screening echo, once they stay for a couple of days, we have to screen in between to see that, because it's very easy for the entire team to put the blame on the lung. But it might just be a sequelae of something that's wrong in the heart, which we just tend to miss if we just don't do it. So that's one thing that we have found useful, that they have to be screened system-wise. And the drugs that we give to these children has to be checked every day. Sometimes we just forget that one drug is just going on forever, and we don't. So every day what we do is we check every drug and see if it is indicated or no, and minimize the number of IV drugs. Make it oral as much as possible, or via NG as much as possible, and least amount of line handling, and so the central venous line comes off as soon as possible. Any invasive line comes off as soon as possible, and as long as it's not required, we don't need it, like that. And then overall care of the baby.
One thing I want to add regarding the ventilatory management, I haven't said about. When it is prolonged ventilation more than 48 hours or 72 hours, and then the important thing is, if we think about the long ventilation, we have to keep in mind our backup, the non-invasive ventilation.
Yeah, non-invasive. Yes, I forgot about it.
To mention, long, that is a high flow nasal cannula, or non-invasive with a via face mask. So it is very important tool, because we always have to keep in mind that we have to give weaning trial as quickly as possible, because the more we keep on ventilating, the more disuse atrophy of the respiratory muscles, and the more we will not be able to take off the ventilator. Another thing regarding sedation I wanted to tell about, that this is a routine about giving fentanyl and morphine in most of the institutes, and sometimes according to the patient, according to the hemodynamics, we have to think other drugs like dexmedetomidine, and sometimes in our setup, clonidine is used as a cover up and to wean off from the sedation effect of the morphine and the fentanyl. Fentanyl is very much potent, so cover up with the clonidine and slowly wean off the sedation. This is very important, because continued sedation can also lead to the two things, that is dependence on the sedation and dependence on the ventilator. So it's a vicious cycle, and we have to keep the days free or the hours free with the sedation. So that is very important. So we have to keep on check. We have to come in few hours of the day. We have to off the sedation, so that the same
sedation
way
vacation has to be given in
it's
between.
very important. And always try to wean, and backup is a non-invasive ventilation that I forgot to mention.
Thank you so much for adding. I kind of missed it as well. Thank you so much. Thank you, audience, for listening to us. Thank you all.
I would request Dr. Shaumen Mehur and Dr. Rajesh to present the mementos to our panelists and chairperson. Dr. Shaumen Mehur is now going to present the memento to our chairperson, Dr. Debashish Bandyopadhyay.
Thank you. Thank you.
Thank you. So hope it was informative.
Now I will request Dr. Rajesh to present the memento to Dr. Srilakshmi. Then I would request Dr. Mehur to present the mementos to our panelists, Dr. Rito Jyoti. Dr. Rajesh, please praise the mementos to Dr. Shatarupa. And Dr. Shivani and Dr. Ali, please. Dr. Shuman.
Photo, please. I was like a laser. I didn't have bullock card. Suddenly I have been asked to ride a fighter jet. Very well.
Minimize ही अच्छे